Welcome to Raaonline program. So today we are going to see a trial. That's a pressure support versus T-Please in weaning a patient from mechanical ventilation. Okay. So first is why this topic. As an emergency physician, we would have conducted a lot of intubations. But how many of us have conducted a lot of extubations or a proper weaning? So in emergency medicine or in your emergency department, weaning is going to be one of the very rare thing. But you need to know how to wean a patient because our emergency departments are getting equipped with the ICU setup nowadays. Moreover, you might see patients who are intubated from outside hospital for various reasons. That could be a transient reason also, like COPD, CO2 retention, sort of things. So when they come to you in an intubated status, their GCS might have improved. So you need to know when to extubate a patient, what are the weaning criteria, how to do a spontaneous breathing trial, and what are the plus and minus of each trials, right? So that's why just to educate on how to wean a patient who is on a mechanical ventilator towards from ventilator to liberated to the spontaneous mode of ventilation is what we are going to see now. So trial 1.0. So this is what we are going to deal with from the New England Journal of Medicine. So this is the journal we are going to speak on. So a small word about the New England Journal of Medicine. It has an impact factor of 176.079. That's a very huge impact factor. What is the meaning of impact factor? This tells about how precious or how important, how significant this journal is. Basically, the impact factor is calculated by a simple formula that in the numerator, the total citations made from that particular journal in the preceding 2 years, and the denominator is total number of publications done in the 2 years. Okay, this is going to be the impact factor of that particular journal in the 2 years. So this is called as impact factor. So this impact factor for New England Journal of Medicine is 176. That's pretty high. It means that more citation has been done from this particular journal. So it's going to be a very, very significant journal. A small word about this journal is it was started in 1812 by John Collins Warren, a Boston physician and scholar who collaborated in 1811 with his colleague James Jackson to establish the first medical journal in New England, publishing the first quarterly edition of the New England Journal of Medicine and Surgery and the collateral branches of medical science, Boston, in January 1812. In 1921, the journal merged with the Boston Medical Intelligencer to become Boston Medical and Surgical Journal, and it also began weekly publications that year and was purchased by the Massachusetts Medical Society. In 1928, it was renamed as the New England Journal of Medicine, which we are currently using now, and is known for many firsts in medicine, including the first to publish a full description of spinal disc rupture and the first to document success in treating early child leukemia, etc. In 1978, it received the first American Medical Journal Award, the Pokman Award. In 1996, it became digitalized, that is nejm.org was launched. So as I already told you, the impact factor is 176.079. So we have chosen an article from this particular journal, the New England Journal of Medicine. So this particular article, the spontaneous breathing trials with pressure support ventilation or a T-Piece, was published on October 26, 2022 at nejm.org. Okay, and this is the link for this particular journal. So what does this actually tell us? Remember that you get a patient who is intubated for maybe any reason. Over the period of days, you are trying to extubate the patient. So what you need to do is, you need to create a situation which can mimic the breathing physiology before intubation, that is mimicking after intubation. Okay, that's what you're trying to mimic. So you can mimic this physiology either by putting the patient on pressure support or a T-Piece. Okay, so which is going to be better? Is it the pressure support ventilation better or a T-Piece type of ventilation better to check whether the patient's SBT is successful? So why this study? Previously, 2019, there was one study named this effect of pressure support versus T-Piece ventilation strategies doing SBT on successful extubation. And this study said the pressure support group has better early extubation rates. There were two more studies, that is in 2017 and 2010, where the effort to breathe with various spontaneous breathing trial techniques were analyzed, and the other studies, physiological comparison of 3 spontaneous breathing trials in difficult to wean patients. Both these trials informed us that there is increased ventilator-free days in pressure support than TPs. So, what is our routine practice when you see a patient who gets intubated and you're trying to extubate him? You need to try weaning process. So, you're putting the patient on from the control mode of ventilation. You're putting this patient on pressure support mode of ventilation to try whether the patient is taking spontaneous breaths, right? That's what most of the hospitals do. So, now the question is, should you really try the patient on pressure support ventilation to check his spontaneous breaths, or can you go ahead with the TPs trial where the patient breathes completely by himself, right? So, this is the two groups which we are going to challenge. Background. The spontaneous breathing trials can be performed with the use of either a pressure support or a TPs. Whether pressure support trials may result in a shorter time to tracheal extubation than TPs trials without resulting in higher risk of reintubation among patients who have high risk of extubation failure is clearly not known. Okay, you might extubate a patient, but the point is the patient whom you have extubated should not get reintubated. There should not be any complications of extubation. The extubation has to be properly timed. So, that's what we are going to see in this study. So, how did we do our study? So, this multi-center open label randomized control trial was conducted in 31 ICUs in France. And inclusion criteria is all the adult patients more than 18 years. That means an intubation done more than 24 hours and the patient high risk of extubation failure. What does it mean? What is the meaning of high risk of extubation failure? We will see that in next slide. And we are considered to be ready to undergo an initial SBT, spontaneous breathing trial. Everybody was included in inclusion criteria. So, what is the meaning of high risk of extubation failure? The patient is more than 65 years of age, had any underlying chronic cardiac disease or had any underlying chronic respiratory disease. So, this group of people were coined as high risk of extubation failure. So, this particular study is targeting only this group of people who are high risk of extubation failure. So, what is the exclusion criteria? Those patients who had traumatic brain injury, those patients who had pre-existing peripheral neuromuscular diseases, and there is a do not reintubate order at the time of the initial SBT. All this group of people were excluded from the study.